that zone will be short. So again, correct placement of the implant is also very much related to this deep zone to stabilize all the tissues that has to be there. And of course, you can choose any component you would want in here when you want to build up something on top of the implant. That will be another transition zone. And the space between the abutment and the deep zone will dictate on how we continue. So here, I would like to talk about the component that we use almost in every case in the anterior zone, which is the connect abutment from MIS. And this is how it works. So the beauty of this is that you don't place it in the implant and screw from the inside. You see the threads here, so you screw this piece into the implant. So what it makes is it creates a biologic seal which won't let bacteria in. And it comes with different platforms, different thicknesses, and different heights. So you can choose whatever you want, case dependent. And the beauty is that when you're planning this case digitally to produce the guide, the software tells you exactly which abutment you can use or you cannot use. So you decide on everything before you even touch the patient. Okay, so how does this work? Let's say when the implant is placed intra-bony, what happens is that when we will start building up the deep zone and start taking this in and out, it will always interfere with the bone. And not only by when using or building the deep zone, but also for the final crown trials, final abutment trials. All the time, these things will go in and out for trial. And when the placement is intra-bony and our connection is right after the implant, we will most likely have bone recession. This is one of the reasons for bone recession. But now when we have the connect abutment, as you see here, and when we screw this into the implant, now what we are doing is that we are creating a one-piece implant. Now it starts from here all the way up. And the connection here is on the soft tissue, not in the bone anymore. And when we torque it like with 30 newtons, it almost like welds itself over the implant. So it creates a great connection with this biologic seal, and as easy as it is, we are gaining that much space to work on the deep zone. Instead of me working from all the way from here to that end, I will just start building up this piece. So easy, tons of times in and out, it will not affect the bone. So I think this is one of the best components we've ever used since the last 10 years, I would say. So when it comes to pros, now we can place our temporary tie-based cylinders on top of the connect, define the cervical zone. This is the most important thing when you're placing the implants. Just like sitting in side ledge position, cervical zone is extremely important because then you make all the planning accordingly. And then after that, when you do your provisionals, we don't care how many times you place it in and out, it won't affect the bone, just a piece of soft tissue. Now, after the implant placement, we have to think about how to treat the surfaces with the provisionals. Why? Because provisional is very important for the soft tissue architecture. The transition between the implant, or let's say the connect, all the way to the crown, we have to shape it during the healing period. So how do we handle this? After placing the soft tissue graft, always we'll place the provisional. However, loading can be a problem. And we have to decide whether we can immediately load the implant, whether we should delay the loading, or don't load anything at all. So here, the simplest criteria is that if you torque your implant with a force 30 Newton or more, then you can easily load this implant, immediate load this implant. And the only thing you have to be careful and pay attention is the concavity here that you have to create, starting from the top of the connect all the way to the line of the cervical margin. So that part will be like squeezed, and the cervical margin will hold the tissue growing further. Now, if the torque is in between 15 to 30, well, we will talk about some delayed loading. However, even if we cannot load the implant, we should be defining the deep contour, which means we should make everything possible from underneath that zone to create this beautiful concave emergence profile. So I will not be loading the implant, but I'm using this abutment to shape the deep zone and the cervical zone. And of course, since I cannot send the patient back home like this, we will be applying a Maryland bridge for the aesthetic outcome, so the patient walks around like this for the next, I don't know, couple of months until it comes to loading the tissues. Now, what if the force is not even 15? Like we made a big sinus grafting, we had very little bone. Probably we should cover the screw and just bury the implant. Now, one thing important is that if you are using a removable restoration, just clear out the areas which comes to the head of the implant. So we don't want that pressure over the implants. Having said that, if we're using implants like B3 with these big threads, it will be really hard not to get this kind of a primary stabilization. So most of the time, we will be able to load the implants. If not, we will be able to place the abutment to shape the soft tissues. So in this case, when it comes to provisionals, we had a different idea with Hsdi, and pretty much we knew in this case that we would be loading the implants, but for some cases which you don't know, which you decide after torquing the implants on how to continue with the provisionals.
Yes, definitely. For that reason, Dr. Gürel and I became thinking about this situation. And I get a call, like I said yesterday, and then we create this shell type of crown, and we create the wing. Instead, if we have situation to not to load the restoration. If we are going to load the restoration, we are going to cut the wings and we are going to use the crown. So what is important is in this periphery, whatever we do, we should touch the special area which is called cervical zone. This cervical zone creates the emergence profile, and it will also create the zenith point of the restoration. So we are creating this kind of restoration in the PM7, and we are using Telio heavily to create this kind of very thin shell and very thin attachment that will going to allow us to hold our restoration if we need it as a Maryland solution.
So this is special design that we came up with. Normally, if you would have a Maryland bridge, normally you should have a pontic here, not a crown. On the other side, if it's going to be a provisional, okay, then it's going to be a shell, but what about these wings? So With this design, we're hitting two birds with one stone, as we say in Turkish, based on whether we can load the implant or don't load, delay loading. So let's say if this is, the decision is that we didn't have enough torque and we're getting a delayed loading motion. Well, then what we will be doing, the only thing here we are not allowed to touch is the cervical margin that Hsdi creates based on the wax up. This is what we saw in the mouth, which the patient approved, and that was the part which was like standing more upright based on our aesthetic design. Because this will set the tone of the soft tissue to grow and stop at the cervical margin, which will define the shape of the tooth. So now if it's gonna be delayed, we'll still be working on the deep zone with this short abutment, which will be tissue level. And on top of that, for the aesthetic purposes, we will be using this Maryland bridge. But to use it now, we fill the inside of it with composite. You just put some flowable, turn it into a pontic, and then just bond it over the tooth, preferably cutting one wing down, because single wing Maryland bridges hold better. So this is how we will go with the delayed approach. Now, what if it is immediate? It's even better. Now we take all the advantage of this design. What we will be doing is that we will cut this part off. We will create, let's say, a hole which corresponds where the implant is sticking out. And from here, we will capture it. And Hsdi can also do it previously and prepare this for me when the decision is made, saying that implant has to be loaded immediately. Chair side, he will take the stereolytic model of the initial situation and the guide, and he will perform a guided surgery in the laboratory.
In this level, you will going to use this stereolytic model, or you can use your plaster model. It doesn't matter, but it's more messy. It will going to create a lot of dust when you are building your model. But in here, it's going to be very easy to stand on the model, on the stereolytic model. The fit is perfect, as you can see on the video. And then you're going to see how I'm drilling this model by using the same drill that they use in the chair side. And I'm going to create this hole with this moment, with the slave on it. You see? And the back side of the model is really capable to put something, to capture the analog part. And here, I'm going to make a little bit wider option, and I go more deeper from the palatal side to create some hole on the Maryland bridge to capture the analog in place. The reason is when they decided to go to load this lateral incisor, and that's why I'm creating this option, because I'm going to cut the wings. I would like to cut those wings while I'm creating nice contact surface with the neighborhood adjacent.
So when he does it, actually, when he drills it through, then this comes like the real situation in the mouth, as if we will have the holes already cut down. So we will be capturing this, let's say, provisional surface, and then Hsdi in the lab will work on the deep zone, and this is the area that he has to create this concavity, which will be transferred into the patient's mouth. Now, yeah, go ahead.
This stage is really important for the dental technicians, because here you have to create a nice homogeneous surface. Shouldn't have any air bubbles inside. It will going to create unbelievable effect on the healing process of the implant surface and soft tissue surface. So that's why I'm taking care about this process in a very close distance with my loop, and I cut the wings and I start to polish the surface carefully to have a beautiful, smooth, really cured, completely cured composite surface with it.
So this is important because now we created the deep zone, now we have the cervical zone, and this is what the provisional looks like before getting polished. So this cervical zone here will stop the tissue growing more and shaping exactly the way we would want that to be shaped. And this is how we go before we captured it, before it went to the laboratory. We place the tie-based temporary abutments, and then here comes the beauty of the wings. Why? Because if Hilal would send me only the temporary crown, let's say, I would need to place it with my fingers to think and to say, okay, this must be it. It's never gonna be precise. So the beauty of the wings is that at this stage, when Hilal opens the hole behind this, let's say, Maryland bridge in this case, I will slide it through the implant, and those wings will allow me to seat it 100% precise. So holding this in position, then I will go ahead and place my global, capture the implant, and then take it out. And when you see it at this stage, the soft tissue looks not even close to what we want, but the shape of the provisional is. So the duty of the surgical team now is to place the soft tissue grafting here, and on top we will be placing our provisionals, and we would wait for the soft tissue heal over our provisionals, so that after a couple of months we'll see the tissue healing exactly the way we want. This is like 12 weeks, and then 4 months, and then it's time to make this impression. So impression, if we make it fast, immediately after we take the provisional, we capture it, and then we place it into the patient's mouth, which copies exactly the same subgingival profile, and then take it out, dip it into your impression, and in this impression, when Hilal pours the model, he will get exactly the shape of the deep contour of this implant.
So when I pour the impression, this is what I see on the surface of my plaster. Of course, I cut the plaster later on when I finish the case. I put it again to show you which kind of modification I have to do right after I receive this impression. The reason is, even with this impression, or even with this emergence profile created on the chair side, I have to make sure that it's correctly placed in correct situation. For that reason, I gently mill the cervical area to create this cervical zone freely in everywhere, and then at that moment we have enough shaft thickness, we have enough shaft length to support our aesthetical part, and we use Emax MO to create aesthetic part of the restoration. So I make the wax, I press the wax, and then we create kind of interesting base, because he is the godfather of veneer, and we always think everything as a veneer approach. And from my side, It's very time-saving and easy to manage the color.
So usually if you have a chance, when you treat cases like this, single implant and veneers next to that, personally I prefer, I don't know Hidayat's idea, I know he feels better like this. Instead of placing veneer, crown over the implant, veneer, which may cause some color problems, we prefer to build up the abutment like a crown, so that once I have this, like another tooth in the mouth, we will just go back to our basics, prep through the APT. So one thing we do different here is that you see these depth cuts and all teeth are ready to be prepped for veneers. But see, I will prep 0.2, the natural tooth, 0.3, the natural tooth, but 0.5, the implant. Why? Very simple, two reasons. When this goes, like when we prep this like a veneer prep, even here we can see a slight color difference. The abutment may not always match with the prep tooth color. So this way, I'm creating an extra 0.2 depth to Hidayat to build this up with a glass ceramic in the lab. Oops, let me back this up. With a glass ceramic, and this will help us for two things. One is, we will definitely get the matching color with the adjacent tooth, but more importantly, if we had a zirconia abutment, yes, we can bond onto zirconia, but it's way too much complex. So it's easier to bond on glass ceramics. So whatever we're covering this up will be a glass ceramic, which can be etched. So we can etch the inside of the veneer, we can etch the buccal surface of this abutment, and then we'll be well off with whatever we'll be bonding onto.
And as a result, I'm going to have such a new case, like a 10-unit veneer case, not a trouble like a veneer crown mixture. It's not complicated anymore. It's just a veneer restoration, same color everywhere, same thing everywhere. So after that, when I finish the restoration, after that, this cementation procedure needs to be taken care carefully. If you have a glass ceramic, you have to etch it. If you have a zircon dioxide, you have to silane it only. But make sure that you are sandblasting the inner surface of the zircon dioxide with 1 bar aluminum oxide, and you are not sandblasting the surface of the lithium disilicate because it can harm the glass itself. So then we use silane on the surface of the die base itself after sandblasting the surface with monomer glass, and then we wait to dry itself. We do not use any dryer or air. Let them dry it itself, and then what we use, sometimes we use very opaque cementation material, sometimes we use translucent, but good to use very opaque material, because this opaque material is going to show you your mistakes. If you have a bigger gap, you are going to see it. And also it will going to hide die base better. But if you have very close distance, it can create trouble and hiding option again. You have to think about this option over and over. Then I cover the surface with the wax before I apply this composite. And before I cure, this is what I like. Before I cure, I clean the surface, then I cure it with the gel on top to protect against the oxygen intubation. Now my job became much easier. I can do my wax up, and it was FTB and floor situation, and my layering starts at that moment. I don't have any trouble thinking that the color is going to be matched or not. Should I change the value specifically on the implant restoration or not? Or should I add more chroma as a color or not? Everything is the same as a 10 unit. I can apply all the colors as the same everywhere, even on the implant restoration, even on the veneer restoration, the same. This layering technique is very simple, very, very simple. What we say always, KISS approach, keep it simple, is the mandatory while you are layering your ceramic as well. If you mix a lot of color, you will going to achieve the gray because it is inorganic colors. So this is the end result on the aesthetic abutment. We have nicely integrated veneer ready to cement. It's not cemented on my side. It is going to be cemented on the chair side, but it has to be used some acid etching surface on the outside of the member. So this is the surface texture that you can see. We would like to use slight shallow surface texture that shows itself very natural way.
So when it comes to the practice, we'll be just bonding those all like a veneer. We've been using the Variolink since years. I don't know which is popular here, but basically this is not the time to talk about bonding to veneers, but usually we choose still the 4th generation bonding agents like a gold standard. So, and we have no intention to change our winning team because we've been bonding with this since years, and we don't see any problems related to the luting resin that we're using. So now we see the implants, we see the restorations on top of them, and let's see how we matched our previous design with the final. So this was, as you can see, the incisal hook-up we created while the patient was during ortho. And when we look at the after picture of the implants, it's almost identical. And then now the things that is changing it in this picture, when the patient starts smiling more and bigger, we'll see a better smile because now we have the control of everything. And even if in her huge smile, we'll be seeing that all the soft tissues are aligned. We have the papilla formation, we have the color match of these designs, and simple enough, this is the final look of this case. So actually, this patient not used to be what was dreaming of being a model, but when she applied for that, they said, with those teeth, you cannot be a model. But after we finish this whole situation, see how much tissue we gained here, and this represents exactly the cervical contour of Hsdi that he proposed us. And we took everything from here on and decided on placing the implant where, how, when, and the soft tissue grafting. So with this, I think we reached to a nice ending for her. This smile, I think, is very acceptable now for her dreams. And we were so happy that she reached out to her dream, which was and now she is one of the top models. And we are so happy if we could have contributed to her smile, changing some people's lives and getting results like this. So again, this kind of cases are never a one-man show case. They only happen when you work as a team. Now, one short last case for you to share, to be on time. What if we have a huge disaster? We have a huge bone loss. So augmenting horizontally is easier, but vertically it is difficult. So if we think about augmentation here, 5 millimeters, maybe stable, and we can do it, but we have to know whether 5 millimeters will be enough for us or not. Why? Because when we think about building soft tissue here, we usually forget about the shape of the tooth. So what makes the shape of the tooth crisp clear? The soft tissue defines the contours. So here, if we don't fill this area, then it will not look nice. And for us to fill this area, we need an augmentation of minimum 10 millimeters. And we have to work with pink, because otherwise, like in some articles shown as nice cases, I don't think they are nice. If you don't have the papilla, if you don't have the contours of the tooth, they don't look nice. So the solution here is to work with pink aesthetics. We will define the shape of the tooth. We will decide together with Hsdi, because the shape of the tooth, whether it be rounded, triangular, case-dependent, patient-dependent, can only happen with the pink that he places around these white ceramics. So it's only then when we bring this into the patient's mouth, you'll have results like this, which prevents patient going under so many soft tissue operations without knowing whether it will exactly be okay or not. But in one go, you'll place the implants, you'll build up the pink, and you will be well off with that. So with this, I think we stick to our time. And as the request of the President, we showed you different cases than yesterday. And if you have any questions and answers, just let us know. Thank you. Is this on?
Thank you for your presentation. Các chị, quý hội thảo viên, nếu các chị có câu hỏi nào thì các chị có thể scan trên màn hình và các chị ghi lại câu hỏi. Hiện tại thì chúng ta sẽ có một cái câu hỏi trong video. Câu hỏi như sau. Thưa ông,